All right, welcome back. Our final session today is always one of our most popular. But before we get to that, I hope that you have had an opportunity to get out there and network. And I just want to let you know that after this last session, we're going to keep the doors open so that you can continue to do that. But please get out there, use the platform, connect with people. And I also want to say thank you for an excellent job utilizing the Q&A. The Q&A box, again, to your right. We want to encourage you to take advantage of that, either asking questions or continue to check the Q&A to see if there's a question you really want answered and vote it up. Okay, so as we get into this last panel discussion, I want to make sure you guys are continuing to do such a great job in the questions so we can get them answered for you. So this session, tips and tricks from Monitor Staff Pros, has some of the most successful monitoring staff from across the U.S. sharing best practices that enhance patient and staff safety and the patient family experience of care. We've got some great panelists. We've got Cheryl Carley from HCA Methodist Hospital, Emmanuel Carrillo, Trinity Health St. Francis Hospital and Medical Center, Megan Fitzsimmons, Oregon Health and Science University, and 2020 AvaSure Video Monitor Staff recipient, and our moderator, Pat Quigley, a nursing consultant and national expert on patient safety, formerly the VA's top researcher on issues such as patient falls and workforce safety. Pat, take it away.
Well, Andy, thank you so very much for that warm introduction for this last session. Thank you so much, Andy, for that warm introduction for this last session as you bring everyone together for learning from our expert monitor technicians as you will get to meet Cheryl, Megan, and Emmanuel. This is so exciting. And as you said, this is tips and tricks from the monitor staff, but I want to say that they're going to share with you their expertise. So let's get to it. So this is so exciting. We would love for each one of you to talk with and tell the participants here from around the country and around the world a little bit about yourself. How long you've been a monitor technician, what brought you to this, and what did you do before this? So who would like to start? Anyone's welcome to start.
I'll start. Hi.
Go ahead, Megan.
I'm Megan up in Portland, Oregon. Before this, I was a CNA. I still am a CNA too, but I did local. So I would be around often. A lot of times I was assigned to a patient one-to-one. The hospital looked into this program and put a lot of effort into it. And from day one, I was assigned to help start the program. I think it works wonderful. I am very happy with it. I put all of my effort into it. And I think it's very useful to have a healthcare experience in this to pre-anticipate what patients sometimes are going to do in their room. But it's been 3.5 years for us now with cameras.
Thank you.
Hi, I'm Cheryl. I'm from San Antonio. I've been doing this for AvaSure cameras for about 2.5 years. We have 30 cameras right at this moment. I got started as a regular sitter and got promoted to do the tech for AvaSure. It's been joyful, a good learning session. I think it's doing a great job in doing what it's supposed to be doing and educating everybody.
Thank you, Cheryl. Emmanuel.
So before this, I worked as a CNA for about 2 years while in college. And when I finished up college with my bachelor's in health science, I kind of got, they asked me to work here at Trinity to start a hub and spoke program for virtual monitoring. I've been a VMA/lead for about 6 months, and then I got promoted to a program coordinator, and that's what I currently do. I love it, and it's great work.
Well, that's just fabulous. Thank you all so much for sharing. So what do you say to people when they ask you about what you do and being monitor technicians and the roles that you have? How do you explain that to other people?
I just tell them I help them with the patients. We have a second pair of eyes to help make sure that they don't pull out the lines, come out of bed, elope. And we are there to help the nurses and the floor staff to keep everybody safe.
Megan?
Well, pretty interesting when people tell me. I tell them I'm part of an enhanced healthcare system, part of a fall protocol safety to keep patients safe. And I let them know that we are there behind the scenes to monitor them 24 hours to keep their loved ones and their patients safe.
Thank you.
So I kind of say the same thing. I say that, you know, I watch patients through a camera for just any type of safety reasons, make sure they're safe and they stay in bed. And we're in constant contact with the nursing staff and make sure our patients are safe.
So as you get to tell people about the role that you have, did you ever have a sense that people might question, well, what is this role going to be about? What do you think? How do you think that this is going to work? Have you had to help talk them into appreciating how important your role is? I think, Cheryl, you have some experience with that.
Yeah, I let everybody know when they're, you have to know your mannerisms. And I always tell them it's like raising kids, you know, when they're 2-year-olds to head up, you know that they're always getting in trouble, they're always mischief, you kind of head off the next step that they're going to go. So if you see the covers move, you kind of know what the next step is going to be. So you be proactive and stop that next step and call the nurse before. So you don't have to do that stat button. I call it the foghorn. So we can get somebody in there so we can help out and keep them safe.
I want to make sure that everybody in the audience heard that the stat button was referred to as the foghorn here. It's an urgent or emergent need to call for help. How about others? You know, because this is new to many organizations and people that are in the audience, not knowing what to expect of the monitor technician's role and being behind the camera.
I can answer some of that. When we first placed the first camera, they were like, oh, another alarm. Because bed alarm fatigue is a true thing. And a lot of times you have numerous bed alarms going off on a unit. The stat alarm is loud. It's definitely a distinctive sound. But when you build a reputation with your staff, we have a lot of verbal interaction that we can use through the camera, which is very helpful. But staff have learned that if we use a stat alarm, it's all hands. And everybody goes. And I found that they don't have that bed alarm fatigue any longer. They are quick to go. They fully trust in us. So we have built a trust by, we go in every morning and we speak to the patient, and we speak to the nurse, the charge nurse, the unit coordinator every day. And they know that we've built a rapport. Like Cheryl was saying, we've learned those mannerisms. So when the foghorn, I really like that, Cheryl, that's good. When it goes off, everybody goes. So the falls or the line pulls or elopement, they're very reduced because of that. It's just trusting in the system and learning to build that relationship.
A lot of people, once they hear us on the verbal end saying, please don't get up, they do come and say, hey, you know, we always say we're the bird in the sky. So they're saying, where did that come from? And it's like, oh, the blue bird in the sky just told you they're watching. So you have to be, they're letting us know what happened. So to keep you safe. And they go, oh, okay. So that helps.
Yeah, absolutely. Did you want to share, Emmanuel?
Yeah, I mean, it's like they said, we are there to just reassure them that we are keeping the patient safe, and constant communication, I feel like, with nursing staff and the patients themselves is crucial, so that they know that we're there and we're not just watching, but we can also speak to them and communicate as well.
I think you had just said something, Cheryl.
No, I got some colleagues here commenting on my blue bird in the sky.
Okay. Well, I just want to bring you back to I'll be right with you, Nate, but I just wanted to, because you brought up the stat alarm and the foghorn, and I just have to make sure that the entire audience knows that how important it is when you activate this stat alarm, because that's when there's an urgent or emergent need. And, the national average of nurses responding to it is phenomenal, 12.5 seconds. And even in COVID, we found 35 point some seconds. So even with COVID and the PPE, nurses are still responding to you when you initiate a stat or emergent stat alarm within seconds. It's just amazing. So I'm hoping, that this is just, as our audience hears already, about how this wow factor that you all bring to, keeping people safe when there's an urgent or emergent need. And, I want to just, then were you going to say something, Megan? I'm so sorry. Go ahead.
Oh, I just wanted to touch base on what Cheryl said. What's helpful is when we're talking back and forth to the patients, staff does hear us very often out in the hall. But I've also noticed, who to call appropriately when you're speaking back and forth to a patient. So there's a lot of reduced useless calls to staffing. If they need their CNA, if they need the nurse. So it really cuts down on a lot. And I found that they respond very quickly. And like Cheryl was saying, they'll hear you in the hall. It's not obnoxiously loud out in the hallway, but staff can hear you redirecting a patient, and that's very helpful.
Yeah, absolutely. So, I know everybody got to hear Dr. Rani this morning, but phenomenal keynote presentation, just extraordinary. And she had a question that was posed to her from, I think, maybe a telemonitor and or a staff monitor sitter. And I just wanted to just bring it back to you because she referred it back to you all. And that question is how did the telemonitors interact with staff? And she was turning it back to you for you to tell the audience about your best practices in interacting with your patients. What are your best practices? Because you know what, she paid you so many compliments during her presentations. And one of those compliments is that you do a better job of monitor technicians of noticing something is going to go wrong. And we'll pick up on that in a minute, but you had so many compliments from her. So if you wouldn't mind, tell the audience about how you create those best practices for interactions with your patients.
We just talk to them, carry on a conversation, try and get back to how they're doing, where they're from, and kind of get the mind off of what they're wanting to do, pulling a line, getting up, taking off out of the room to prevent everything that we're there to help to prevent. And it gets their mind off the topic of trying to jump out of bed, pull a PICC line or a permacath or a peg tube. And you get to know their history. I've been talking to ones that have been singing and wrote songs for Willie Nelson, TV crews. It's really been interesting, some good backgrounds. You get to learn a lot about the patient and you get a good rapport. So it's good.
Thank you, Cheryl. Please continue to share, colleagues.
So I think, I love building relationships with my patients, each and every one of them. I just have a better conversation. It's not about just redirecting them the whole time. I ask them how their day's going, how's the weather over there, or, just get to know them so that when it comes time to redirect them, I can build off of that, of what I know about them, and they listen to me better. So just being more than just a voice telling them to stay in bed or don't do this or don't do that, it comes a long way.
Mm-hmm.
Yeah.
Thank you.
Yeah, it helps.
So in the mornings at our hospital, we go around to each room and we go into the patient's room. If they're awake, we'll come back later. I mean, if they're asleep, I'm so sorry. But if they're awake, we go by. And I wanted to share something with you that we found to be very helpful. So we hang these, and it has a picture of us on it with our name, and you will hang these on the camera. We ask them first if that's okay. So that way during the day, if they're forgetful, they put a face with the voice. As Cheryl was saying, we get to know them, their family, where they're from, and maybe what's their profession, their likes, dislikes, and it helps. We go in person, make sure that they're comfortable, and throughout the day, we can build on that. And I wanted to touch briefly, I know we're limited on time, but I had a patient, and she was unfortunately there for a long time, but we were always telling her, don't touch the ninjutsu, don't touch, don't. So we'd find distractions. And I want to tell everybody, don't be afraid to be silly, because come to find out the staff loved this and didn't tell me till later, but they would stand outside the room and listen to me. So I would call the patient by her name, and I'd be like, hey, you're stuck with me again today. And I would tell her, like you were saying, sing a song. We would sing Take Me Out to the Ball Game. We would also be like, I'm 7th inning stretch. I'd be like, reach for the sky, put your hands up, jazz hands, right? You know, and I would ask her, can you stretch them way out? It was things, so she didn't have to keep hearing say, no, don't, leave that. You have to make the personal touch. You definitely are still very involved in their care. It's wonderful to do that. So if you put that effort in, the patient has a better experience. You have a wonderful day. The family members and hospital staff have a wonderful feeling about this program and how well it works. You definitely can find ways to make it personable. And I just want to tell everybody, don't be afraid to go do that. You'll have a wonderful day doing that. And verbal interaction, it's great. Those patients will talk back to you.
You not only get the patients, you get the family members talking to you and carrying on. So they're more likely to like it, because a lot of them think that we're invading their privacy. And once they realize we're there to help and to help them in a bad situation when they get irritated and stuff and they need some help, we can get help in there faster and call directly to the nurse or floor staff to get in there. So they really like it.
Absolutely. And I just wanted to mention too, Megan, your organization, Oregon Health and Sciences Center, you were credited the AvaSure prize last year, but you're the ones who, your organization, your program published the first and only article that measured patient and family satisfaction with the engagement. So that's pretty impressive, to be able to have that quantified, that, they really felt assured and safe, and everybody was really preferred this program over sitters. So, it's non-intrusive. So congratulations for that. But, you all do that, creating these relationships with patients. So again, that's a tribute from that Dr. Rani turned back to you. So did you want to add more to it, Emmanuel?
Yeah, I mean, I've had patients that, they try to get out of bed a lot and pull on things. I remember I had one patient, she had mitts. She was tied down in restraints, and she continued to try to get out of bed. The redirecting wasn't working, so I found out that she loved dogs off of talking to her. And when she eventually, what I did was just sat there and talked to her about her dogs the whole time. And it kept her in bed with her arms crossed and just having a conversation with me. So sometimes redirecting doesn't work, but talking and engaging keeps them safe and in bed. So yes, I agree 100%.
Yeah. Thank you. And Megan, thank you for sharing that recognition, the photo recognition too. That's pretty innovative. Cheryl and Emmanuel, do you have other innovative strategies that you've used in helping people to know who you are, the person behind the cameras, that you want to share with everyone?
You're echoing really well, hard. It's hard to understand. Am I coming across echoing?
You're doing just fine.
Oh, all you guys are echoing, so it's hard to understand. I'm sorry, can you repeat what you said?
If you had a method to help the patients and the families know who's the person behind the camera, do you have one of those methods that like Megan had shared?
Yeah, I always introduce myself and we talk back and forth, give them a little history that I've been doing this for 2 years. And I always come across again is they always call me the camera lady. So the video lady, and they kind of laugh and gets them in a good humor. And then I ask where they're from and we go back and forth and tell them that if there's anything they need, just kind of wave at me and I can pipe in and ask what they need and need help and I can get them help for them.
So for my end, I'm part of a hub and spoke model, so I'm not physically on at the hospital like Cheryl, Megan, but so it's kind of a challenge to not be able to have them to see us or have a picture of us. So what we do is we introduce ourselves in the morning, and we have them write our names on the board along with our numbers, and then we just kind of, as we introduce ourselves, we reorient the patient to, time and day and say, good morning, my name's Manny or Emmanuel, and I'm going to be your video monitor for the day. If you need anything, just wave at the camera or, try speaking to me and I'll talk to you. So that's kind of how we do things with the hub and spoke model.
Mhm. Thank you all so much for sharing. So let me take you back to that other compliment that Dr. Vanny gave to you, to all the monitor technicians who are in the audience or those who are doing all of this great work, because your role is just so vital. And that is, she said that you are the best. You do a better job of noticing that something is getting ready to go wrong with a patient. Can you give us an example of something that you observed when you knew something was getting ready to go wrong and how you handled that and got the staff involved? Can each of you share an example of that? That was such a wonderful compliment. Emmanuel, would you like to start?
Yes, I'll go first. So not a story from myself, but one of the VMAs that work here. She was watching a patient throughout the day, and in the morning, the patient was, doing perfectly fine, talking to her, it was engaged. And throughout the day, she saw that the patient progressively, wasn't responding as much to her. And so she said she felt like something was wrong with the patient after seeing the patient throughout the day. And asked if the nurse can check in on the patient. So the nurse went in and checked on the patient, and the patient was unresponsive. And they got someone in the room. The patient was a full, code, and they were actually able to save the patient. And the patient ended up in the ICU, but ended up surviving. So who knows how long it would have been until the VMA had let someone know that something was off with this patient. So
Saving
Yeah, I had one when I first started that he was doing good in the morning. In the afternoon, his breathing was different. And all of a sudden he panicked and tried to get up. So I called the staff in their stat and they went in and he went down and they ended up doing CPR and took him to the ICU. And they said, if I didn't get anybody in there what he did, he would never have made it. But he's doing great. He had a good life ahead of him now.
Saving lives, Cheryl. Yeah.
I had a case just yesterday. I was monitoring, watching a woman, and they brought in her tray. They had set her up in a chair and she had tomato soup. And I was looking at her, and all of a sudden she dropped the spoon to her soup. And I looked and she started having facial tics all of a sudden. So I urgently called the nurse, and then they called the neuro team in, and they progressed along the way. But because we were monitoring, if we wouldn't have called with the difference, the team wouldn't have immediately been in there. But I also want to say, just not even on the part of the health with a code or something like that, we've also had patients where families come in, and I was like, well, all of a sudden they're acting a little strange. And I was like, well, that's funny. They grabbed that bag and went in the restroom, urgently called our staff, and come to find out family members had brought in alcohol, brought in cigarettes, brought in a lighter. And then we've also had people come in and, have the weapons. So a lot of times you're looking for a difference, whether it's in the medical condition taking a change or the behavior for self-harm, situations like that. You have to really be on it and catch those things.
And you're sharing that as being yesterday. You've been doing this work for over 3 years. Cheryl, you've been doing this work for over 3 years. Emmanuel, you've been doing this for years and just got a promotion. This is the things that you can actually see every day, isn't it? Changing lives, saving lives, working with the staff.
Yeah, we get to know our patients well because we are watching them 12 hours a day. Sometimes they're on cameras for almost 2 weeks, sometimes, depending on the situation. So we get to know their mannerisms really well, and the visitors that come in.
Yeah, we've also caught low blood sugars. So the same thing, we know them very well. And we're like, oh, well, if that patient's diabetic, they're not acting right. They're acting very sleepy. We've actually had that happen numerous times where we've urgently called the staff in there and the patients have had extremely low blood sugars. So there's a lot this program offers when you start learning the mannerisms and helping keep a close eye on them.
You make the case for ensuring that monitor technicians have clinical experience, as we have people that are probably attending the symposium that are still deciding on, the criteria for who are going to be telemonitor technicians and staff. How do you get involved in orienting new staff? Tell us a little bit about how you make that happen.
With us here at Methodist, we bring them in and they sit with a core staff for anywhere from a day to 3 days. And then during that process, we, towards the end, had them do it on their own, but we are sitting right there one-on-one with them and see how their personalities work with the patient's personalities. And not only that, they have to know how to talk and react to the nurses when they get reports and how to get a report and what to ask for in a report.
Mm-hmm.
So for here at the hub, what we do is I'm I actually help develop the orientation process for us, but we have 1 day of orientation where we go through all the AvaSure health streams and programs. I train them on the cameras. And then after that, for about a month, they're sitting each week. They start off first shadowing a VMA and seeing what it is. And then they switch positions and the new orientee is watching the cameras while VMA is overseeing them. And then about week 2 or 3, they get put to 4 cameras, 6 cameras the next week, 8 cameras the next, 12, and then so on and so on. And until they're comfortable with how many cameras they're watching, then they fly solo. So it's kind of how we do it here.
Mm-hmm. Thank you.
Mm-hmm.
So up at Oregon Health and Science University, what we do is we give them 6 12-hour shifts of orientation. And we start with just the basics of how does the program work? Like literally getting on your computer, learning how to open the program, and then learning what to do if there's a downtime. Who are we going to call? How do we work that? How do we troubleshoot everything with the cameras? And then we start getting them into what are we looking for when we're going to admit a patient, all the information that we need. We run them through that. But we slowly start them in that. So for the first 3 days, we're training them on the whole program, our protocol for report, admitting, speaking in. And then the last 3 12-hour shifts, we are there to shadow them and teach them how to run up to 12 patients on the camera to watch. And if they need any more time, which they have never needed more time though, we are willing to offer that to them, but they seem to do really well with 6 days of orientation.
And I bet every one of you, each of you remembers the first time you had to verbally interact with someone from behind the camera, don't you? I see you all smiling. And so do all those technicians that you bring on board, right? The first time they interact. How'd that go? Tell us what you remember about it. And then we have a question from the chat.
I'll totally answer. I'll start.
Okay.
So nervous. I went to the green microphone to speak, and I was shaky and it didn't quite go. And then I finally remembered, pulled it down, and I was like, please don't get up. I'll get you help. And the patient was startled too at first. And I said, oh, I'm so sorry. I said, I need you to wait and I'll get you help. And the patient goes, well, why do I have to wait? And I said, well, I need for you to use the call light because we want you to have somebody with you when you get up. Well, where's my call light? And then it just disappeared. It was easy. I was like, oh, well, your call light's right there. It's the same button that you use for the television. I said, just push that red button. I said, and then I need you to wait. But that first time I went to hit the button on the mic to speak and I was shaky. And then just like that, it went away and you're just comfortable. Once you get over that initial hump, it'll come to you naturally and you'll want to interact with the patients.
Yeah.
Yeah, my first time, when they first introduced AvaSure to the Methodist, that was an hour. And then I showed up for my shift and I said, here you go. And I was left by myself. So I did it all. And to me, I grew up in the healthcare system. My aunt ran nursing homes. She was administration and my mom worked in them. So I grew up and it's just like talking to people. You just got to carry on the conversation and keep going. And you have to, it's multitasking. You have to know how to talk, push buttons, and call the nurse at the same time.
I agree. It's like learning to ride a bike. In the beginning, you're nervous, you're scared of falling. But once you do it, you got it. And from there, but I have to say, AvaSure did an amazing job by having their educators come and help us learn. I remember Nick, he was one of the educators that came and he really got us comfortable with using the system and talking. So when it came time to actually redirect the patient, we were nervous, but we were prepared. So.
Yeah. And then what to do when you see the first adverse event that happens, because we know falls are so rare, even with AvaSure, but when they happen, we know what happened. It was a witnessed event. So the safety net is so phenomenal. So let me tell you about this question that came in from the chat, colleagues. On average, they want to know how many patients one monitor technician is comfortable monitoring at a time. So how are you handling that at each of your programs? I know it's different for you, Emmanuel, because you got the hub and spoke model going. But still, how many patients are your monitor technicians observing?
I'll answer for us. We monitor 12 at a time. And with the monitors, that gives you a good view of your lines, drains, and your patient. I know that the monitors can go to more, but we feel safely, especially we tend to run a higher acuity right now with patients. Once the nursing staff learns to trust you, it's amazing the acuity of the patients that you have with numerous lines, drains, C colors, wound vacs, etc. They're on a vent, so 12 is when you know what you're doing and you're comfortable is very manageable. I don't know about you others, but that's our average, is just a 12.
We have 30 cameras here in Methodist, and we have 2 screens, and each screen holds 15. And our average per screen is anywhere between 12 and 15 a day.
Yeah, for here at the hub, it's a little bit different because our numbers can fluctuate and go up and down at any time. So we say 12 is the happy medium. We have the ability to watch 16. But at any given time, since we can watch up to 243 cameras at one time, and 60% is our goal, we keep it around 12 per VMA just to keep it on the safe side.
Thank you so much for answering the question that came in from the chat, and let people know how you do your handoff to one another.
Report. We do just like a bedside report. The next shift comes in and we tell them, report on each camera what happened on our shift. And we go by the additional notes. If anything extra happened on our shift, we add it to our notes. We make sure that that person is aware so they can tell the next person coming in after them. Any DCing of lines, adding any lines, anything, surgeries, anything that we know of, that's in our report from the whole 12-hour shift and all the cameras that we are running.
Mhm. Are your practices about the same, Emmanuel and Megan?
Yeah, ours is pretty much the same. For us, we have more people here on site. So when you have 10 or 12 people, we just tell them, keep your eyes on the screen when you're giving a report. Don't turn to the side and look at the person you're giving a report. Just, one by one, go through each person, go over the additional notes and what you know about that patient. And then moving forward, the oncoming VMA ends up doing their own kind of review of the notes with the nursing staff to make sure everything is still the same because things change. So that's how we do it here.
So up in Oregon, what we do is we have a runner position, so a video monitor runner. That person is in charge of moving the cameras around, but also at shift change, that person is responsible for watching the cameras while we are giving report to each other. So it's pretty much like they have all said, do you want to know any lines, drains, transfers, surgeries, possible discharges? Were there any adverse events over the evening? We do that one-on-one on staff. We get settled in to watch our 12 cameras a piece. And then what we do is we let nursing staff get report on the floors. And within 30 to 45 minutes, we call them and also get report from the nurse and then check in with the nurse and the CNA also to see what plans that they have. It's just kind of a little double report going on. We found that it's helpful because we've been told somebody, doesn't have a line, and then the nurse is like, oh, we had the camera on privacy, forgot to tell them they do have a right form, PID or something. So a lot of times if they didn't tell the tech and that happened when the camera's on privacy, we've noticed that we've got the information from the RN the first hour in the morning.
Yep.
And all of your examples help our audience to know how much communication goes on with the telesitter program. And that's the communication with the nurses that you get as well as communicating with one another. So how do you build rapport with the nurses at the shift, on the unit level? How do you build that rapport?
I had to say for us, it was difficult in the beginning because there were certain hospitals that came in brand new, so they kind of went along with our processes and how we do things. And then there was some that we took AvaSure cameras was already in place locally. So they had to kind of switch their ways and kind of conform to how we do things. So in the beginning, it was difficult and it's still a challenge, but we're still working on it.
It's hard. The new nurses are still balking the cameras, but you call and say, hey, I got a dumb question. You got a minute? Can you call me back? Try and work into their schedule so that they can give you a report. You get more information if you work it that way than you just say, hey, I need it now. So kind of work with them and work on their terms and say, is there anything new we should know, just so you don't get 40 million phone calls this shift? And I can put it to my notes so everybody knows from the next shift so we can keep things going. And they said, oh yeah, that's fine. And we usually get more information. Oh, I'll just grab my notes and give you the whole report. So it works out.
Mm-hmm.
So I can say for my hospital, what we do with that runner position that's been very helpful is they will go out onto the units and they go and touch base. They're like, introduce themselves. So I would be going around saying, hey, I'm Megan. And of course the staff all know you, but you still always introduce yourself. You tell them, I'm going to be the runner today. This is the tech, that's dealing with the patients that you have on camera today. But we stop and touch base with everybody, and we make it very personal. And we're like, hey, we got your back today. And they're always like, oh yeah, we couldn't do it without you. So from the beginning, we tried to make it a very positive thing, as in we're not taking over, but we're just part of the team. We're enhancing the safety protocol for the patients. So by letting them know, we're not going to alarm fatigue you, we're not going to call you unnecessary. I found that they're so grateful. I mean, we get calls constantly. It's why we're expanding the cameras in our program, is they built that trust because we've been right there with them every day, introducing ourselves, asking, is there anything that we could do better? Anything that yesterday we were monitoring the patient. So we let them give us feedback. We don't always just direct and tell them how it will be. So the teamwork with the cameras has been wonderful. And like I said, we make sure everybody knows. So even the secretary at the front's going to answer the phone. They know who we are working that day. And, like the holidays come around sometimes and we're like, oh, hey, VMT just brought a little bag of kisses. We wanted to just tell you how much we really appreciate you all. And those things go far in building trust and teamwork.
Well, you all are fabulous, and we have only 3 minutes. I mean, we can never have enough time with you. We have 3 minutes left. So with that, if we could just have you each just say briefly, because people want to know what the impact of COVID was on what you did. We have a publication that just came out and this year about AvaSure and COVID. But how did COVID impact you? But if there was anything that you learned or anything you could have done different, what would that be now that you have this experience with you? 3 minutes and counting. They're going to cut us off.
I just wanted to say, with the COVID, I was very grateful that we had the program, because the visitors at all were, of course, nothing. So we had patients that were in rooms alone, and it was a wonderful opportunity to talk to them and let them know they really weren't alone. We were there, and that you could ask them anything and let them know, hey, we're going to be in there very soon. Staff is on the way. And then you would ask them simple things like, what is it, that you want to do today? And they would say, well, my goal today is to be able to sit up on the bed. And you're like, all right, well, how are we going to make that happen? But a lot of times they were left alone in the room. But in hindsight, they weren't, because they had us. And they will chat to the best of their ability when they were sick with respiratory and things like that. And family, a lot of times, really appreciate that. Once they got to have like the one visitor in there, they would be, thank you so much for being there for my mom or for my grandmother. And that made me feel like COVID didn't leave people so isolated, and that I was still an important part in healthcare doing this.
Yeah, it was nice. At our hospital for COVID, we also had a tablet that we called or FaceTime the family members. So when they get really agitated and really restless, we will let the nurse know, and they're asking to call and talk to somebody. At that point, they would grab the tablet and bring it in so they can FaceTime their family members, and it helped a lot.
Yeah, I agree. For me, it would be the nursing shortage. That is, we've seen that a lot, and for us, it's being a helpful hand to them during COVID and being in the room so that they don't have to, and then just being non-judgmental when they call and they're upset or something's going wrong, just because they have a lot of patients to take care of. There's not enough nurses, so we kind of just be empathetic to them and yeah.
Well, that too, and when they get uncomfortable and we get the nurse in there, but they have to gown up, and that takes a few minutes with all the stuff they got to put on. So we can talk to them and try and keep them from doing what they're doing until they can get in there. That helps.
Well, colleagues, this brings us to the end of our sessions, and I just want to say to you that you are respected, you are trusted, and you are essential. And to all of our people in our audience, our monitor technicians, monitor staff, telesitters, if you'd please go back and say that. And before you have our pros, our experts here that are trusted, who are respected, and who are essential. So let's all give each other a big round of applause. I know everybody else is applauding you. Great job. I'm going to reach for the sky with you, Megan.
Thank you, Pat.
Great job, everybody. Thank you. And I'm
you.
going to turn it back over to
Thank
Andy. We
Thank you.
never have enough time.
Love you,
Well
dogs.
done.
All right, that was awesome. Thank you, Pat, and thank you all the panelists. Well, that's a wrap for day one, everybody. What an absolutely fantastic program. We encourage you to continue the conversation. Use this as an opportunity to talk to your peers. We're going to keep the virtual doors open until about 5 Eastern. So please keep those conversations rolling. And we have so much more to talk about, so let's keep it going. Tomorrow, virtual doors will open at 10:30 a.m. And we'll kick things off with an 11 a.m. keynote with John O'Leary, who will inspire you with his story of surviving and thriving following a life of change, a life-changing experience. We want to remind you too that if you've got questions, please continue to use the Q&A box tomorrow. But if you didn't get a question answered today, please visit avasure.com. Send us a note. We're going to make sure that every single one of those questions are answered. Again, thank you for your time, your attention. Be safe, and we'll see you tomorrow.